Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
I'd like to welcome our audience to today's episode where we're going to be speaking with Dr. Golden, who I'm going to allow to introduce herself, and then we'll get started with our content.
Hi, I'm Angie Golden. I own NP Obesity Treatment Clinic in Flagstaff, Arizona, and basically treat patients with the chronic disease of obesity using evidence-based practice.
Well, obviously that's a topic we could probably spend weeks on, but we will definitely be focusing on some very specific parts of that today. I'm wondering if we could start our conversation with you discussing a little bit about the overlap of obesity and diabetes epidemiology.
So I think the interesting part that a lot of people are starting to recognize is obesity really is the cause of type 2 diabetes in about 85% of patients with type 2 diabetes. There are about 34 million people in the United States with type 2 diabetes, adults, and 85% of them do have obesity versus 140 million people with obesity. So are we looking at a growing epidemic, even more so for diabetes? Probably, if we don't start making headway in this almost pandemic of obesity that we have. So I think that's why it's so important to understand the connection between the two.
So as a clinician, what kinds of triggers do you see for people coming to your facility that maybe they've recognized that interconnection, or perhaps they haven't, and that's something that you end up helping them recognize and learn?
So it's interesting. A lot of my patients come to me from family referrals. They have family members who already have diabetes and obesity, and they don't have diabetes yet. And so they come really to prevent that from occurring for them. Others are coming because a primary care provider may have told them, if you could lose weight, you might be able to prevent or reverse your prediabetes. So a lot of patients are coming with, that early beta cell dysfunction. So I do see that, but also have a fair number of patients that, they still come to me just like most of the world thinks that it's a cosmetic thing, and they're just coming because they want to lose weight, and they don't understand that excess weight, that excess fat cells have the potential to cause 236 other obesity-associated disorders. So I think for some of them, that first visit is a real eye-opener to realize that this is a chronic disease and it can cause so many other things, including cardiovascular disease and cardiometabolic things like diabetes. So sometimes that first visit can be a kind of long one as people start to let that kind of settle in for them.
You've spoken a little bit about the fact that obesity is indeed a chronic disease, and we've seen the stigma around obesity shift in recent years. And I'm wondering if you could speak to a little bit about people with obesity, people with overweight, and that maybe that first conversation and how to do that most respectfully and so that the patients feel respected and listened to in that clinic visit.
I think your point is so well made because so many of our patients with obesity and pre-obesity or overweight have just had such a horrible time in a place they should have been the safest, the healthcare environment. The bias and stigma of healthcare providers has been shown in the research to be some of the toughest places for patients to be. So I think the way to do it is just, first of all, be sure you know if you have your own bias and stigma around obesity. And some of it's self-blame if you're a person with obesity. You're already self-blaming yourself, so it's a lot easier to reflect that out. So be sure that you've checked that before you start the conversation. And then I always tell people, talk like you would to your best friend, kind, empathetic. Let people know this is a safe place for them, that there's no judgment, so that they can have the conversation. And the Stop Obesity Alliance, you can Google them, they're out of George Washington University, has excellent examples of ways to start the conversation. sometimes in my family practice, I'll start the conversation with things like, I've noticed that your BMI has gone up a little bit. That's different than your weight. Your BMI is kind of a different number. Sometimes people don't even know what BMI is. And so it's a curious way to start the conversation. And I'll ask permission. That's the first thing. Can I have your permission to talk about your weight today? And before I stop that question, though, I will say, because I have some tools that can help with that. And I'd love to be able to have a conversation with you about it. Because if you stop, can I have permission to talk to you about your weight? The first thing the patient may think is, oh, another person to yell at me, another person to tell me I should eat less and move more. Like, I don't know that I'm fat. I mean, that's what's going on in the patient's head. So I'm quick to say I have some new tools that might be helpful. And that way they know that I'm there to help. I'm not there to judge. And I think those are really important, but the biggest thing is to do it in an empathetic way. And then understand how it's a chronic disease so you can explain that to them. Because I think that's the second piece of this whole puzzle for people is, I know myself as a woman living with obesity, there were numerous providers that had come in to say things like, you're overweight. You need to lose weight, right? Well, yeah, I have a mirror in my house, is what you want to say back to them, right? But offered nothing really in response to that. So I think letting people know that you're there to listen to them, that you understand they have a chronic disease, but you have to be able to explain what that means if you're going to open the conversation to start with.
We are having a fascinating conversation with Dr. Angie Golden. We'll be right back.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
We're back with a little bit more information for you about how to talk to our patients with obesity, about the condition, and some tools that they have available to them. And I'm wondering if we could shift our conversation just a little bit to talk just a bit about medication utilization for both obesity and for diabetes.
Absolutely. So, we've got some new tools in our toolbox that really are pretty remarkable because of the impact they can have on both of those diseases. We've got GLP-1 receptor agonists, which have been used for years for patients with diabetes, and now we've found that at some higher doses, some of those same medications can be very effective for, again, bringing down the hemoglobin A1C, but also having a good impact on weight loss. Now, the number on the scale is not our end result that we're looking for. What we're looking for is, by losing weight, having a greater impact on the chronic disease of diabetes, hypertension, hyperlipidemia, the 236 other diseases. But now we've also got the new dual agonist for diabetes, not yet approved for obesity, but that does have significant weight loss that's being seen in the trials when given to patients with diabetes. So I think those new tools are really starting to show us that we can have great impact treating two diseases with one medication. And then the exciting part is you add in cardiovascular, those same medications are starting to show some really interesting long-term help with cardiovascular outcomes as well. So how exciting is it that we can do one thing, one tool in our toolbox, one medication, and impact three different, very large chronic diseases in the United States?
It is an exciting time to be in this field and seeing what the changes are that are on the horizon. And I'm wondering if you have any resources that you would point our listeners towards to find out more information as it becomes available.
So I would look at the Stop Obesity Alliance. They have some really great information for providers. The Obesity Medicine Association has a freely available algorithm that is updated each year, so it stays very current. And then there's Canada also has an obesity guideline that not only has parts for providers, but also has a section for patients. So it has some nice handout kinds of things that people can use in their clinics to give to patients.
And I would think that one of the key treatment options is making sure that patients feel empowered to advocate for themselves, but also to describe to, let's say, family members who perhaps don't understand this as a chronic disease. Is that accurate?
Absolutely. I think one of the things my patients take away from my clinic every time is the handout on how obesity is a chronic disease, and also the shared decision-making handouts, like how to select an eating plan that will work not just for them, but for their family life. And the shared decision-making on how to select a medication that might be right for them. I think that ability for the patient to be a part of that decision-making, it's critical across every chronic disease, but especially obesity because there's so much bias and stigma, as you mentioned from the very beginning, around it. Our patients having an opportunity to be so engaged and then be able to turn around and explain to their families everything that's happening in their treatment plan. It's an absolutely critical part of what we're doing in obesity management.
So as we're thinking about treatments, I'm hoping you could address for us the paradigm overlaps in those treatments that are available or are on the horizon.
So I think starting with just the baseline of treatment, it's the same for obesity, cardiovascular, and metabolic. And that's a good lifestyle intervention plan. I mean, it all starts with helping people have a relationship with food that's healthy, learning to be more active. I don't use the word exercise because a lot of people think of exercise as having to go to a gym. Just be more active. Maybe it's going to be gardening for one person. Maybe it's walking their dog twice a day instead of once a day for another person. I mean, just so individualized. And then especially that behavioral intervention piece, which some people go, ooh, that sounds kind of complicated. It's really not. It's just about teaching. Because when we are teachers, we're listeners first. We hear the roadblocks that our patients are coming up on, and then we help them find a way around that roadblock. That's what behavior intervention is. So that's our baseline of treatment. And then we use what else is in our toolbox, whether that's medications, and for obesity, it might be surgery if the patient meets certain criteria. But those medications impact the pathophysiology of the disease of obesity, just like our medications for diabetes impact the pathophysiology of diabetes. So we need to keep that in mind at all times. These aren't vanity drugs. They're not really weight loss drugs. They're impacting the neurohormonal pathophysiology of the disease. And those support the patient's ability to stay with their intensive lifestyle interventions.
So in your practice, obviously, we are talking about pharmacotherapies, we're talking about lifestyle and behavior change. And do you, in your practice, have a support system available, or do you have resources that you can connect the patients to help these patients as they progress in this treatment?
So many obesity practices do. I don't. I live in a pretty rural area, so I do all of it with my patients. I help them select their eating plan. I help them stay on track with it. I help them progress in their activity. Now, I do have a couple of physical therapists that if the patient has specific issues with movement and stuff, that I will refer patients to in order for them to get that taken care of, but not specifically part of a team. Now, some of the bigger obesity practices will have dietitians with them that understand the disease of obesity. They'll have exercise physiology teams. They'll even have psychologists or counselors to help with that. And there are some excellent online tools. That said, I do have a couple of my patients who will use, for instance, Weight Watchers as their eating plan. I'm 100% behind patients utilizing that. It's a well-established program for an eating plan. They just show me that that's what they're using, and if they have any roadblocks when they're trying to do it, I help them maneuver through those. So as long as the patient is comfortable with whatever eating plan they've chosen, that is a healthy eating plan, then I'm great with that. And that's a great community resource for a busy practice to use too. And it's just an example of one. There are many others that people could use, and some are online, which make it easier for patients to utilize.
I do appreciate the fact that we live in a time where there are options available. It's not just a one and done, because not everything, as you've described, works for every patient. So having this wide diversity of things online, in person, family support, shared decision making, all of those play into the success for our patients and helping them, do what they want and need to do so that they can be as healthy as they possibly can.
And that is the absolute bottom line. It's not about the number on the scale. It's about living their healthiest life.
Great words from Dr. Angie Golden. Is there anything else that you would like to add that I've neglected to ask? I
think I would just ask the listeners to start being more proactive. Patients with obesity who are sitting in your clinic, when their weight isn't brought up, they feel invisible. So learn how to bring the conversation up and learn what the resources are in your community if the resource isn't in your practice, so that you can help them find the care that they need.
Thank you so very much for these great words of wisdom that we can take and apply into clinical practice tomorrow. You have been just a joy to speak with today. We are so grateful to you for your time, Dr. Golden. And this is Geraldine Warfield, your host, and we will see you next time.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.